So this, was kind of one little bright light that finally in the dark history of melanoma that we're making some progress. And this is where we go targeted therapy. So now we don't only target the patient in terms of what the tumor is doing and what it's doing to the patient, but we're very specific in targeting the tumor itself by determining whether or not it has this mutation. If you give the vemurafenib to people who don't have the mutation, it doesn't work at all. So you have to test to see if it's there. If it's there, it works. If it's not there, it's useless. One of the holy grails of melanoma oncology has really been immunotherapy. We have known for decades that the immune system is intricately involved in the control and the spread and even the eradication of melanoma cells in the body. And IL-2 experience tells us we can exploit this. We don't know how, but in some patients it works. There's been vaccines for years tried, and in some cases they can cause tumors to regress, but we never quite know how to do it, and certainly we haven't done it to the degree that we need to. And so finding an effective immunotherapy in melanoma has been sought after for many years. And so again, the flurry of New England Journal articles, one came out about ipilimumab. And this is an immunotherapy which also has been shown to improve survival in patients with metastatic melanoma. So this drug works by basically revving up the immune system to attack the foreign body by interfering with its braking system. And so one of the issues around this drug is it can cause autoimmunity. In other words, your immune system can start attacking yourself, and the side effects are related to that. However, so this just shows how it works by basically taking the brakes off the immune system. So in a large study, again, comparing standard treatments to ipilimumab, this is where it was given in conjunction with a vaccine, which basically didn't work anyway. But in order to see that it was better than a standard approach, patients who had previously had chemotherapy were randomized to getting the ipilimumab and alone, or with the vaccine, or versus the vaccine alone. And basically it showed that the patients who got ipilimumab, whether it was with the vaccine or not, increased their survival by at least 4 months and reduced their risk of dying in half. And this is a curve to show that if you got ipilimumab, you did so much better than if you got just the vaccine alone. And this is also showed something unusual in that here in for the screening, you can see those big melanoma lumps on the guy's back. Then received the ipilimumab, and they actually started to grow after receiving the drug. But it was only at 16 weeks they started to regress, and then by week 96 they completely disappeared. So you saw an expansion of the tumor and then regression. And the regression took quite a long time to take. So if you start a drug usually and you see the tumor growing on the drug, that's not usually a good sign. But in fact, in the use of ipilimumab, that's not the case. It can grow and then start to regress. And so it causes us to think a little bit differently about how we evaluate these patients. And in terms of side effects, they're basically, I told you it can cause autoimmunity, but most of these side effects are really very manageable. The most common one is diarrhea. Again, if it's identified early and treated aggressively, it's not necessarily a big problem. Also, it can cause hepatitis, so we have to monitor liver function. It can cause other endocrine effects like your thyroid and your pituitary gland, but these are generally manageable, but you got to watch the patients to look for them to occur. So I've told you about 2 new drugs. This is a list of a whole bunch of other ones that are currently under clinical investigation. Some are targeted, some are immunotherapy, but many of them have promise. And it's really important in melanomas that we test out these new drugs. So our standard of care is, even with these new drugs, is to try to put people on clinical trials so that we can improve the benefits of what we know already, but also see the potential further benefits that can be realized by using some of these other agents. So it takes a double whammy to figure out how to solve this metastatic melanoma problem, but it's nice to see we're making some headway. And with that, I'll finish. Thanks.